Good afternoon, everybody. I'm Sterling Johnson, the Associate Director here of the Alzheimer's Center, and it's my privilege to introduce Dr. Julie Schneider today, our keynote speaker. Dr. Schneider is the Deborah R. and Edgar D. Jannotta Presidential Professor of Pathology and Neurological Sciences and the Director at the NIA-supported ADRC at Rush. She's certified in geriatric neurology and has a master's degree in clinical research. In addition to directing the center, she leads the clinical neuropath initiatives for the religious order study and the memory and aging project and other landmark studies at Rush University. Dr. Schneider has extensive experience collaborating with researchers, participating in multi-site grants and initiatives, and being a critical thought leader for our field, and especially in raising the collective consciousness of the field and awareness around multipathology that is present in our patients with presumed Alzheimer's disease. More recently, she's been helping pioneer the concept of late TDP-43 related encephalopathy, and she'll be talking about that today. Her work leverages her expertise in neuropathology, neurology, and epidemiology to advance discovery of mechanisms, risk factors, and biomarkers, and prevention and treatment options for Alzheimer's and other related dementias. So with that, please welcome Dr. Julie Schneider to the stage.
Thank you so much for inviting me. It's such a pleasure to be here. Even though I live very close, I don't come to Madison very often. So it's really been fun to come here. And it's really exciting to see everything that's going on here. Very exciting. So let me get started because I don't have a lot of time and I have too many slides as always. So I'm going to be talking about what do we see in addition to Alzheimer's in the brain. But you'll see it's not really instead of Alzheimer's, it's not really beyond, but often these are together with Alzheimer's disease. I was asked to, I'm going to just go across here so you can see my slide. I was asked to say a little bit of something about myself. So I thought I'd just give you a brief history of how I got to where I am. I actually did most of my training in Chicago. So I did a neurology residency at University of Chicago, followed by a neuropathology fellowship at University of Chicago. Moved to Emory, where I worked with Sue Mira on Alzheimer's disease and neuropathology, went on their staff, and then came back to Chicago. And I've been at Rush ever since, where I've been doing mostly clinical research, really looking at people and their brains in aging. So I've been fortunate enough to be part of several longitudinal epidemiologic studies that I'm going to tell you about right now, and I'll show you some of the data from those studies. Our studies enroll volunteers like yours do, and here we see them yearly for annual testing, and we want to see what's happening as people age in the community in real life. So here we enroll people without dementia at baseline. We don't exclude them if we do cognitive testing and it looks like they have some impairment or even dementia, but we say come as you are, and we're going to enroll you, and then we're going to do yearly follow-ups. So we do cognitive assessments, we do risk factor testing like you guys do, medical histories, of course, blood pressure, blood work for diabetes. We do MRIs of the brain, blood draws, and then we have many, many sub-studies over the year where we're looking at things like you guys are, like diet, and things like decision-making and susceptibility to scams. We have questionnaires. We also look, I'm not going to have time to talk about it today, but we also look at traumatic brain injury. And we do questionnaires for, have you ever had a traumatic brain injury? And if so, did you lose consciousness? Sorry to have my back to you for that. And then we have wearable devices also. Things like how much activity you're having, how quickly you walk, how long does it take you to walk a certain amount. And the unique part of our studies is brain donation. Okay, so the religious order study began in 1993, and everybody who enrolled in this had to agree to brain donation. So they're altruistic people who are in the community, and they all live together, so it's easy to go to their places and evaluate all of them rather than going house to house. And I'll show you a couple of pictures. And they're very fastidious. If they say they're going to do something, they do it. So we have great autopsy rates. And usually generalizability of autopsies is not good because people don't, even if they say they'll do it, they don't call at the time of death, right? So it's hard to do autopsy studies. The Memory and Aging Project we started several years later so that we could get a more general population because religious disorder study has a lot of very healthy people who get health care and they're very cognitively active in that group. So we began the Rush Memory and Aging Project in the Chicagoland area in 1997. So now this has been going on for over 30 years. I've been part of it for 29. It's a long time. We've evaluated over 4,500 people and we have over 2,100 autopsies from them. This is where we go for the religious order study across the country. When I first started as a neurologist, I went and saw the nuns and priests and brothers. Here's us doing some of our testing. It's very easy to go to these places because they're all living in the same community, and often they'll have cemeteries right on the grounds. So they're dying there also, versus, the community where it's much harder. Our Rush Memory and Aging Project goes within the community of Chicago. It takes just as long to get to some of those places as it does us going to California. And here we're going to variable places in terms of socioeconomic class. We get a little bit more variety of age. So we go across the country, all the way from Chicago to New York to California. And then we go, here's the pictures of people getting tested, the religious orders. Here we go throughout the Chicagoland area. And to get a wide variety of different people, we also try to get variable race and ethnicity, though it still was hard for us to do this in the Memory and Aging Project because we ask for brain donation again. To enroll, you have to say, I'm going to donate my brain. So here we are in the Memory and Aging Project. We added a minority aging research study, which is Lisa Barnes, and I think she's given talks here before, in order to start getting more of a minority population, the African American population. And there we know you have to build relationships before you say, hey, can I have your brain when you die? So here we really got involved in helping the community, telling them how important it is. We're learning so much from white people. What can we do in other races and other ethnicities to learn about the brain? Here, and I did change the slide, we have over 100, and I think it might be getting up to 150 African-American autopsies from the community, which might be right now the largest data set of African-American brains. And here's Lisa Barnes. I tried to keep up both. Here's Lisa Barnes and some other staff giving talks in the community. So this is our model. Our model is we evaluate you every year. And then as you get older, people die for a whole bunch of different reasons. They're not necessarily dying from dementia. They're dying from their cancer, from their heart disease. So we get people who die with normal cognition, mild cognitive impairment, as well as dementia. And we have what risk factors they had along the way. We have blood along the way. We have other assessments that are happening on a yearly basis. And then we get their brain. So what did we find initially? AD pathology is extremely common in older people who are, quote, normal. This has been confirmed recently with biomarkers, as everybody knows now. But when I started, no one believed it. They're like, oh, you just didn't test them soon enough. If you would have tested them right before they died, you know that their cognition was impaired. The other thing we've learned, and I'll talk to you about, is mixed pathologies. You've heard about that today, that there's other things going on in the brain other than Alzheimer's disease. Loads of vascular pathology. If there's one thing to get across to a lay population, is you really can help your brain by helping your heart. That vascular disease is really important, not only for the heart, but for the brain. And then the last thing which was mentioned is TDP-43 in the brain, which is really an exciting new development and now has the great name of late. Okay, so, So AD in the brain of cognitively normal people. So we saw that around a third of our older people who die with normal cognition have Alzheimer's disease, a pathologic diagnosis of Alzheimer's disease in the brain. This is what it looks like, this classic plaques and tangles. This has actually been described for decades. No, that's okay. Keep telling me. I need it. It's been described for decades. So in my last slide, I was showing that this has been described in manuscripts from the 70s, 1970s, that people are dying with, quote, Alzheimer's in their brain. And so what they used to think in those days was, oh, well, you must need not as much when you get older because you can be normal and still have the pathology. So there's all these different excuses about why you would have pathology but still be normal. But now, of course, we know that I have to go backwards, sorry. Now we know, of course, through the great stuff that's going on with imaging, that people do have amyloid in their brain while they're aging. So when they come in with their amnestic syndrome, they often have amyloid positivity in their brain, but they don't always have it. And that normal people have amyloid positivity in their brain commonly. And that's why the diagnostic test or using it a diagnostic test is difficult in the community. So what is the predictor? I think this is one of the main questions everybody has. You have a person who comes in with amyloid positivity in their brain, and this is going to happen in a huge number of people over the age of 65 or 70, right? What are the predictors that your patient or your loved one is going to decline? That's what we really want to know, right? We don't care if we have it if we don't have dementia. And here we know there's a lot of risk factors. So we know that your age matters. We know your genetics matter. We know that if you have diabetes or psychosocial, if you have depression, that somehow makes it worse. Your lifestyle, social, physical, cognitive activities all matter. You heard earlier from one of the presenters about diet and protein in the diet. Diet seems to matter. There's all these things that seem to either protect you or push you towards cognitive decline. And one of the things we were interested in, because we had the brains, well, how about other pathologies? So when I did my neuropathology fellowship, if they had AD, you didn't care if they had a lacunar infarct in their basal ganglia. You just said it was incidental. They still had Alzheimer's disease. You didn't care about a couple of Lewy bodies in the nigra. So we wanted to look at that very early on. So here's AD pathology. This is a Lewy body, the classic Lewy body, in the substantia nigra in neuromelanin cells, where that's in inclusion in the cytoplasm that's round, eosinophilic. And here's an infarct in the putamen of a brain. So we found, this was early on in the religious order study, we found that if you have probable Alzheimer's disease, you more often have mixed pathologies. Even if an expert says it's Alzheimer's disease, you more often had AD with infarcts, or you had AD and Lewy bodies, or both. And this is in the community. So it's one thing to have it, right? But how do we know if it's causing a problem? So one thing we did is we measured how much AD pathology you have on the x-axis and what's your probability of dementia on the y-axis. The lower line shows with increasing AD pathology, as you'd expect, the increase of dementia goes up. But what we found was that every level of AD pathology, your risk went up if you had one or more infarcts in your brain. And these were often very small incidental infarcts in the brain. So we were quite surprised, astonished really, by how much of a difference it made for their likelihood of having dementia. This is Lewy bodies now. So same thing. If you add Lewy bodies, exponentially just rises your chance of having dementia if you have a neocortical Lewy body in your brain. And this is in people mostly without Parkinsonism or significant Parkinsonism. And here's a cortical Lewy body, a little bit harder to see for the neuropathologists, but we have better antibodies now to look at than we did in the past. Okay, so catch up now. So vascular pathology is ubiquitous in the brain. So we started off with these infarcts, and they're common. It's common to see these silent infarcts in the brain. You see it on scanning all the time. You know, you see a patient and they have a small little infarct somewhere in their brain, and you're like, okay. So it's very common. But there's different types of tissue injury, and there's different types of vessel disease, and we're very interested in this. So, and also some of these infarcts are really small. So the thing that I just put up, it came up on the right corner, is a 2 millimeter or 1.5 millimeter infarct. You can't see that with normal imaging. We can see it on the brain. And we can see also microscopic infarcts. Under the microscope, we see an infarct, but you can't see it on imaging. If you put the two of these together at death, around 50% of our older people at the age of 90 have either a microscopic or macroscopic infarct in their brain. 50%. This is atherosclerosis. So not only will they have infarcts, but they'll have vessel disease. Around a third, a little bit less, maybe it's around a little bit less than a third, will have moderate to severe atherosclerosis at the base of the brain. Another third is going to have significant amyloid angiopathy, which is more related to how much Alzheimer's pathology you have. And another third are going to have arteriolar sclerosis, or what the neurologists used to call lipohyalinosis, which increases your risk for white matter hyperintensities, lacunes, small infarcts. So we see all this in the brain. So here they all are again. This is how many people, if you take a group of people with AD dementia, an expert diagnosed AD dementia, this is how many people will have either tissue injury, vessel disease, or both in people with AD dementia. It's hard to get old and not have some vascular pathology in your brain. But again, just because it's there doesn't mean it's bad, right? So what we want to do is we want to say, okay, is it worse if you have some of these microscopic infarcts? So these models now tell us controlling for age, sex, education at every level of AD pathology. If you have this vascular disease, are you at a higher risk of having dementia? And the answer was yes. So here's the first one I showed you with one macroscopic infarct. This is what happens if you add a microscopic infarct, which actually surprised us quite a bit, to be honest with you, because it was a reviewer who asked us many years ago. We're like, oh, these aren't going to do anything. And sure enough, it doubled your risk. And then over on the right, what about the vessel disease? What if we see all this vessel disease, but we don't see any infarcts at all? And here you can see with AD pathology alone, your odds is around 20%. Now you add atherosclerosis, arteriolar sclerosis, large infarcts, microscopic infarcts, and your odds of having dementia have just gone up over twofold, almost threefold. So people have the same level of AD pathology, which everyone always used to wonder about, but the person with the vascular disease is the one who's exhibiting dementia. And the other part of this, and I won't get into this too much today, is that because we're Alzheimer's researchers, we were only looking at the parts of the brain pretty much that we thought was going to have Alzheimer's disease. We weren't looking at regions that might be more susceptible to vascular disease. So one thing we did is we looked in the watershed regions. We looked in those regions of the brain that might have decreased flow when you have hypotension or have low flow states and you get older. And indeed, we found more microscopic and regular infarcts in the brain if we looked at these watershed regions of the brain. So we have even more than, because you don't look, you don't see it, right? So we weren't doing a complete survey of the brain. The brain is large. The other thing to mention for my imaging colleagues is in pathology, we don't see everything. And imaging does a much better job of certain things. For one thing, with white matter, it does a much better job with white matter. But here, what I'm showing you are large perivascular spaces, and I'm showing you microbleeds. Again, these do a really good job during life as biomarkers of vascular disease, and they match onto what we see with pathology, but show it to us better than the pathology does. So there's the vascular pathology I've shown you already doesn't even do justice to the amount that's out there and adding to the contribution of cognitive decline and impairment. So big factors here, a lot of exciting stuff. And then the risk factors. So you hear on the news all the time about things like blood pressure, and whether or not it increases your odds of dementia and vascular disease. So one of the things we wanted to do is just, and the studies vary, right? Because blood pressure is such a hard thing to study. People go up and down and they get nervous when they with the white coat syndrome, and then people have really high. When it gets lower, it's still high. It's very hard. You really need longitudinal work with blood pressure, and it's very complicated. But we wanted to know is if somebody has high blood pressure, do they have more vascular disease? Simple question. The answer was yes. They have more infarcts in their brain and they have more vessel disease. But what we found in our older people was that as their blood pressure started declining, they also had more infarcts in their brain, suggesting what cardiologists have known. Not only does your your average blood pressure matter, but perfusion also matters to the brain. We also found trends in postmortems. Because we have so many years of pathology now, we were able to show, looking at the different pathologies across the brain, how things are going down. So larger infarcts over time are now decreasing if you look at postmortem trends. Atherosclerosis was decreasing. Interestingly, small vessel disease was not increasing. I mean, it was pretty much stable, as well as AD pathology. So you can look at societal trends on what's happening. And indeed, we're taking better care of our heart, and it's showing in the population. They have less large vessel disease. They have less of these things. Now, also, just so you know, this is in people who die at an average age of around 85 to 90. So we're not talking about the 50, 60-year-olds. Also, what we realize is that these vascular pathologies also affect things that we traditionally think of as being Alzheimer's disease. So we think of the hippocampus as, well, that's just Alzheimer's disease when it shrinks. Now, we find that if you look at our cohort, their atherosclerosis also will predict hippocampal size. We also find that there's other interactions between vessel disease and AD pathology. So a lot of work now is really focusing on vascular disease and Alzheimer's disease and how the two either interact or add to each other in the process of cognitive decline and aging. Okay, I know I only have 5 minutes left to talk about TDP. I'll get the hang of this right when I'm done. So TDP-43. TDP-43 was described in I believe it was 2006. It was, and here you can see it on a photomicrograph. It's often associated with hippocampal sclerosis, often on a background of Alzheimer's disease pathology, but not always on a background of Alzheimer's. So you can see it with or without Alzheimer's disease pathology. So TDP-43 was first described as the protein that was in inclusions in ALS and FTLD, ubiquitin positive inclusions. It was described. I remember Trojanowski coming to our group and saying, this is really neat. We have this. And I'm like, maybe we should try it on our older people and see if older people also have this. So it was initially thought only to be associated with FTLD and ALS. But we found, and other people found very quickly, that we see TDP-43 inclusions in the brains of older people, both with and without dementia, more commonly if they have dementia and Alzheimer's disease, but in people with and without dementia. In one of our first studies, we only looked at 100 people and found a really significant effect of TDP-43 on cognitive decline. And that steep line, if you can see it, is showing how faster decline there is in people with TDP-43. That's that top graph. if they have the 95th percentile of TDP-43. Not only was it really have a large effect, but it also had a large effect size. Our statisticians told me, oh my God, this is almost as much as what Tangles is doing. They said, don't put this in the grant application. They're going to say you don't even need to do the study anymore. It's like with 100 people, we already have this incredible magnitude of effect. We also then showed that if you have mixed pathologies, you even have a greater odds of having dementia. So on the lower right-hand side, you have an increase of dementia if you just have TDP-43. You have an increase for dementia if you just have AD. And then in the red rectangle, you can see what happens if you have both AD and TDP in your brain. Same thing if you look at decline. We looked at the top line is if you don't have either, then you have late, then you have AD pathology, and then you have both. And again, look at the rates of decline. The top graph is showing you global cognition, and the bottom is showing you episodic memory. And then we looked at people in our cohort who did not have pathologic diagnosis of Alzheimer's disease. And we said, what's driving people when they don't have Alzheimer's disease? And it was all the usual suspects, except TDP-43 was really having a strong effect. So it was infarcts, it was Lewy bodies, there's vascular dementia, there's dementia with Lewy bodies, but the other thing there was TDP-43. So there was an explosion on TDP-43. We were seeing it pathologically, as it had not been heard of for the most part clinically, but we thought it needed a name. And like anything else, naming things can be a little bit tricky. I didn't vote for this one, and this was not a popular choice for a lot of people out there, but we ended up naming it LATE, or as you can see up here, limbic predominant age-related TDP-43 encephalopathy. It's not the best of terms, but it stuck, and we call it LATE for the clinical syndrome and late neuropathologic changes for the pathology that we see associated with it. And one of the reasons was that TDP-43 was thought to be frontal temporal dementia, and we really wanted there to be clinically people able to name this something, because we know this is happening and it's increasing with age and becoming more and more common in our very, very old population. It has a similar distribution as AD, a little bit less of a neocortical footprint, mostly temporal. It has a propensity really to affect memory. It's associated with slower decline than Alzheimer's disease. So these people in your clinic who sometimes seem like they're really kind of going slowly down, but their hippocampus is really small, they're likely to have late. And there's progressive atrophy of the hippocampus. It really mimics AD, a slow AD, when it's alone. Because it's so important, we have now moved to, we have biomarkers for AD. How about what do we call people who don't have AD, have episodic memory loss, but they're amyloid's negative in their brain? I asked this recently at an esteemed residency. I won't tell you where it was. And I said, what would they have? What would be their problem? They're like, stroke? I'm like, what if it's not stroke? What if their MRI is clean? They're like, I go, what do you tell your patients? They're like, they really didn't have an answer for what do you tell somebody when they come to your clinic with episodic memory loss. They don't have Alzheimer's, their amyloid scan's negative, and yet their scan looks clean. They don't have vascular risk factors. They're not Parkinsonian. They have no fluctuations or hallucinations. What do they have? My guess is they have late, and that's what the studies are showing now, mostly. And so we have new criteria. I'm not going to go through this with you, but you can jot it down. The reference, we have new criteria. Really, it's somewhat of a rule-out diagnosis right now, but we're really trying, as you know, to get biomarkers. And this is both from an imaging as well as a fluid standpoint. And this is just some more of the clinical criteria. So I'm going to summarize a couple things. I think I'm out of time. So first of all, when we do say you have Alzheimer's disease, I wanted to point out you usually do, especially an expert clinician who says this is Alzheimer's disease. This is without biomarkers. What I have there are people with probable AD and MCI in the rectangular box. Most of those people have Alzheimer's disease. Everything that's blue in those circles, those pies, is Alzheimer's disease. We say you have Alzheimer's, usually you have Alzheimer's disease. The difference is you usually have mixed pathology. Usually you have vascular, Lewy bodies, or TDP, and there's a little sliver on the right of AD alone. You can see if people with no vessel pathology, no infarcts, no Lewy bodies, no TDP43. So most people that we call probable AD, they have something else in their brain. Might not be contributing a lot, but they have something else. By the time they have mild cognitive impairment, they have an awful lot of pathology in their brain. You can see a big swath of that pink is vascular, but there's also a lot of AD already. Over half of them have AD pathology once they have mild cognitive impairment. And then look at the no cognitive impairment group. Over on the left, very few people have nothing. That zero is on the relatively small side. Over a quarter have Alzheimer's disease or mixed pathologies, and a bunch have a vascular TDP or other neurodegenerative diseases. So let me go one more. So persons without symptoms that have all this pathology in their brain, that's usually what you're going to be seeing in older people. These are people in their 80s usually. They have some pathology in their brain. Things to remember: lesser pathology is probably better. So you have less infarcts, less vessel disease. All that stuff is probably better for your risk of having dementia. So heart health equals brain health. And that there might be compensation from other pathways. So it's not only that you have less pathology, there's probably other things happen. And how do I know that? Is because we've looked, and other people have looked, and things like cognitive activities, physical activities, social activities, diet, they're not very much related to any of these pathologies. When we look in the brain of these people who have great diets, they don't have big difference in some of these. I thought for sure they have less vascular at least. They really don't have a lot of differences in pathology. We really had to look for it. Same thing with neurobehavior, depression and anxiety, or some of the medical illnesses. Something else is happening in the brain that really determines whether or not you're going to be resilient and manifest dementia from the pathology. So just a couple new things. I added on the right there that we're now using digital quantification to get even a better sense of some of these pathologies. Because traditionally, we just look under the microscope and we say mild, moderate, severe, or we count things. But we're really able to use AI now to really start counting things well. So we're doing that in our lab. So we're now, instead of looking, we're actually having the computer tell us how much amyloid there is or how much tangles there is, or things like that. But the other thing that we really became interested in, especially because the genetics is so intriguing, is inflammation. What about inflammation? Do some people have more or less? Yes, with the same amount of pathology in their brain. So what we showed is that if you look at hippocampal microglia, the amount of microglia inflammation in the hippocampus, that independently predicts cognitive decline or episodic memory decline, over and beyond the tangles you have there and the TDP43 that you have. Both of those are related. You have more tangles, you get more inflammation. You have more TDP43, you get more inflammation. But the actual inflammation itself that you get, the more you have, it's the worse for you. So how do we decrease that inflammation? What things can we do? What kind of inflammation is it? So other things are happening in the brain that are going to navigate whether or not you decline related to these pathologies, how your brain responds. So these are exciting times in our field. We have all this AI stuff going on, which you guys are going to have now in your pathology, which is really exciting. We have other things that we know are happening in the brain that we can now measure. Things like inflammation, where we're really learning that it's not just the pathology that's glopping on, it's how your brain is responding, removing or reacting to that pathology. So those are both exciting. And then there's biomarkers. So imaging biomarkers, we're working on several imaging biomarkers. There's lots in the fluid field. Something very exciting with TDP43 are these cryptic exons that they're finding in biofluids. TDP normally regulates DNA RNA splicing. When it doesn't attach to those cryptic exons, the exons get incorporated into the mRNA, and then you can see the funky proteins that end up on the right-hand side, nonsense proteins, proteins with inclusions that you don't know what to make of. So this TDP-43, which moves from your nucleus to your cytoplasm, when it's not working right, when it's not attaching to your DNA like it's supposed to, you start making all sorts of weird stuff in your cells, and it's not good for them. So in summary, no, that was a whirlwind tour, but Alzheimer's pathology is very common in, quote, normal aging, in normal older people with normal cognition. It's often mixed in people with dementia. Other neurodegenerative and vascular pathologies are really important in of themselves. Lewy bodies, vascular disease, TDP-43. And they all have varying trajectories over the course of someone's lifespan. So we know that AD kind of plateaus at some point, whereas TDP and vascular continue to go up. Vascular disease, very important. Be aware of late pathology. Resistance to pathology is important, but resilience really might be the key to maintaining your cognitive health in aging. So I want to thank everybody, all of our participants in our study and all our investigators, the Rush Alzheimer's Disease Center. Come visit us sometime. We're not very far away. Love to see you guys. Thank you.
Say thank you, Dr. Schneider, for this, and sorry about the technical
My technical
gymnastics. Thank you for doing that. And you're also multitasking today with NIH Council, so thank you for being here and for doing what you do with the NIH Council as well. Do we have questions for Dr. Schneider?
That was an excellent presentation. Exciting work that you have going on. I was just wondering, at Rush and giving back or disclosing biomarkers to participants, especially cognitively normal participants, how are you guys approaching that? And kind of where do we go from here for those folks that are in this preclinical stage?
That's a great question. And stay tuned because we are working on that like so many people are. And I know Clarity is helping us with that because you have definite instructions. But we also have the added part that we see a lot of African Americans, a lot of Latinos, a lot of people who may be where we have to think about how we give these results to people. So we are right now thinking about going in the field and actually asking people, what is it that you do want to know? Would you want to know this information if we were able to give it to you? But I think that everybody's navigating this now. I think everybody out there is trying to figure out what to give back to help and not hurt.
Over here. First, thank you for coming. Such a cool presentation. I think the co-pathology is very convincing. Gives me a lot of questions. So I have two questions. One, did you look at epilepsy or subclinical epileptiform in that kind of cognitive reserve framework?
So we have looked at medical records of epilepsy, and we found that epilepsy in our age cohort, or seizures, I think is what we coded, was related to a couple things. Was related to infarcts, not surprisingly, right? Cortical infarcts. Was related to CAA, again, not surprising. Cerebral amyloid angiopathy causes microbleeds. It was not related to hippocampal sclerosis or TDP-43. So the mechanism really seems to be that cortical irritation in aging, at least and our numbers were small, just so you know. And we're not doing EEGs on people. This is just their medical record EEGs or seizure history.
Okay. And did that see an increase in that probability of developing dementia kind of in that chart you showed as well?
The numbers were too small for us to be able to actually look at that because there is a whole literature, right, about epilepsy and increasing risk of dementia. So I think you need a different cohort to do that.
And then the second question is more of an opinion question. Given the NIH framework of amyloid as the pathology, does this fit into that framework, or does this provide evidence that we should downgrade amyloid as a risk factor or actually the pathology?
So that's a great question too. Amyloid's bad for your brain. I think there's a lot of evidence that amyloid's an initiator and the things that are downstream to amyloid are bad. I don't think we know whether these other neurodegenerative pathologies are downstream. Things like TDP-43 or Lewy bodies sometimes seem to be downstream, but not always. Sometimes they're in people without that pathology. So I wouldn't say downgrading might not be the right way of putting it, but I would say we need to give equal emphasis to these other pathologies and the way the brain is responding to pathologies. I think amyloid alone is a difficult thing to target.
Thank you so much.
That question?
Hi there, Dr. Schneider. That was a really wonderful talk, and thank you. I look a lot at neurodegeneration on MRI in relation to amyloid and tau. I know that the late people are in my sample. I know they're amyloid positive, which kind of clouds the interpretation of results relating to amyloid. I also see them in the amyloid negative group, where you see this really definite pattern of hippocampal atrophy. I wonder, in the absence of biomarkers, is there some way I could estimate possible contributions of late? Could it be like a medial to lateral temporal ratio of neurodegeneration? Is it something I could do on the basis of age? Like, okay, not that many people who are, 75, 80, and so on.
So look at, that's a great question, by the way. And that's what everybody is, not everybody, a lot of us are looking for right now. If you look at this manuscript on the diagnosis of late, there's a little bit of discussion about those biomarkers, imaging biomarkers that people are starting to use in order to get a handle on how does the hippocampus differ when it's with TDP or TDP-43 on its own. None of them have been verified. Everyone's working on it. We're working on a TDP-43 biomarker. There's multiple groups working on it. But you can look through the paper and see if any of those things appeal to you yet. But something's going to come out to help us with that answer. And you're right. It's the people who have both that are really declining, right? And if we could figure out the people with amyloid and TDP-43, that'd be really important.
Awesome. Thank you.
All right, let's give Dr. Schneider a round of applause for that wonderful and timely presentation.